We'll start with Professor Victor Chong. Victor is very well known to all of you. Victor is currently Global Head of Medicine, Retina at Boehringer Ingelheim. From September 2021, he'll become Global Head of Retina R&D at Janssen Labs in the US. And he is currently President of the new Subthreshold Ophthalmic Laser Society. No better than Victor Chong to deliver the following lecture. Victor, many thanks for joining us.
Ladies and gentlemen, thank you for allowing me to speak to you on macular laser photocoagulation today. And I think the talk is about whether it's still relevant in 2021. I think the one we need to focus on that we need to put in that some years ago, macular laser is the only available treatment. Now we have the additional option. So instead of thinking about that we should stop using laser or we should only use other therapy, I think that we're thinking about how it's relevant in 2021 and how to use those different things in combination. And indeed, anti-VEGF therapy is very useful therapy. But I think that laser is still relevant. And I'm going to share with you my talk today. So this is my financial disclosure. I'm an employee for Boehringer. This talk is not endorsed by Boehringer and it's not really relevant from a topic point of view, but it's slightly more relevant. I'm a consultant for Quantum Medical, and which is a laser manufacturer. And I'm also a founder and director of EURETINA Limited, which is a device company to providing a therapy for a small device for therapy for early DME and intermediate AMD. Again, probably not relevant to what we're discussing today. So the question number one is, I heard a lot of my European and Asian colleagues said that, oh, when I went to a US conference, they say that they don't use laser anymore. And so I think the first question was, well, do our US colleagues actually still use laser or not? So I think that, we can answer that question by looking at a study that was published a few years ago and comparing the 3 different types of anti-VEGF. And again, it's focusing on diabetic macular edema and so-called the protocol T. If you're looking at the baseline characteristic at the time, that there is about 600 patients was included in the study, but you can see that about 36 to 39%, more than 1/3 of patients actually have laser before they join the study. And I think I recall that at the time that they were really keen for patients who were not treated to join the study. But yet, there is quite a number of patients that would have laser before. And then again, if you're looking at that, they in the study in the first year, they need about just under 10 injections, all had more than 9. And then, but when you look at that, how many that still require laser treatment despite the 9 or 10 injection. And I can see here anything from 37 to 56%. So again, it's something that when we think about that, you started with about 1/3 of patient have laser, you end up to have another half the patient still need laser during the first year despite 10 injection. And I think that we can conclude is that even in a quite recent US study, laser is still carried out in the majority of patients. Don't get me wrong, as I mentioned in the introduction, that I think anti-VEGF is extremely useful to our patient in our management. But I think that how laser they actually still use in that circumstances. So the question number 2 would be that who should we treat with laser and how should we deal with patients when they come to us in a different stage of the disease. And go back to one study that I was involved in, which is a bit older study now, but it's one of the original study that have really comparing 3 different groups. Unlike some of the study that you use anti-VEGF first and then you only use laser later. And in this study, you had a pure randomization. In other words, what I mean by that is we got one group have Lucentis ranibizumab alone. You have another group, all of them would have ranibizumab as well as active laser. And then one group that will only have active laser. So I think it's really that to comparing those 3 scenarios when we actually when the patient come into us when they have DME with some degree of loss of vision. Again, I don't want to bore with the fine detail, but just to highlight that if you're looking at the differences, the different groups when they were looking at the level of edema. So to your left, that when you have less than 300 micron, bear in mind, this is on the time domain, there is a quite old study, I accept that. And so that was in the modern day, like say Heidelberg would be equivalent to around 350. And even at that level of edema, you can actually see that the three groups really don't differ very much. And on the far end, that yes, when you got a more than 400, so in modern scale, more than 450 or so, that yes, definitely, there's no doubt that anti-VEGF with or without laser are superior to laser alone. But even in the middle group, that considering the number of laser required, and actually that you can still debate whether that laser will be still a valid option on its own. However, that no doubt that laser would be beneficial in some of those patients. Similarly, that when you actually look at patient that whether that they should have combination or not, and the thing to think about it, this is a study with patients who have DME, and you can argue that those who have prior laser, in the fact that those are the laser failure already, and indeed that quite a lot of my patients who have laser don't need any further, don't have DME anymore, and therefore that they would not actually join the study. So I think you need to put that into perspective. And again, in here, that for those laser failure, then you probably do a combination would not necessarily particularly helpful as shown here. And then Lucentis on its own clearly showing superiority. However, you never have laser before, a combination seems to be slightly better. And although it's not statistically significant, but numerically better. So I think that, we need to think about how do we treat patient, that is something that we put into consideration. And more recently, that the question was that what if you got good vision and essentially you more DME, that what you want to go and do about it? And I think a lot of people would quote the protocol V, and those are patients with DME and 20/25 or better vision. And again, you probably heard about the fact that you should just observe as good as using anti-VEGF. But I think that what is not often highlighted that in this particular study that there is laser group. And that in fact, that what happened, that as you can see in this graph here, that laser reduced the risk of Eylea injection requirement from 36% to 26%, and that is a 34% reduction. And bearing in mind, laser is a relatively straightforward procedure, but if you're reducing something for 34%, you would expect that people would talk a lot more about it, but you probably have not really heard that, and therefore that might be something that people decided that laser is actually not needed. Now, what what we need to think about is that all that I show you so far are with standard laser, and indeed that in the society that we are now formed in the subthreshold laser society, ophthalmic laser society, that we really want to improve that from standard laser and how can we do better. And again, today might not be had a long discussion about some subliminal laser, but again, you probably know quite a lot about it already. And the laser energy deliver impulses and that give less collateral retinal damage and then no visible scarring. And I think that is something that we can show you a very quick example with an edema there and with exudate and fluorescein angiogram showing microaneurysm and which was leaking, and then OCT showing the edema. And then you can then have the laser, and this patient only had one subliminal laser, and then 4 months later, the edema gradually go away, and so as the exudate, and then slowly that 12 months later, that all the exudates goes away, and then you would not see any scar formation. And similarly, that an OCT that will show the benefit that way. So I think that to summarizing the laser for DME, so I think that laser is still used in real life and even in the US. And then when you're actually looking at the claim data, that yes, laser use have reduced. However, that bear in mind that anti-VEGF use have increased substantially. So I think that you need to kind of considering that both treatment are coexisting. Laser are similar to anti-VEGF in early DME, and so when you only got mildly involved with thickness, but if you got to come with a patient who got very thick retina, and I think anti-VEGF is something that we should consider. However, that even for those with thick retina, that if they were never been treated with laser before, and then I think a combination treatment is still justified. And however, that I would not use conventional laser, and I will use subliminal laser. And it's already mentioned that in DME with very good vision, and again, observation is an option. However, that laser can reducing the risk for anti-VEGF therapy for more than 33%. So I think something that consider. And again, as I mentioned, that all those evidence I showed you are on DRCR-NET clinical trial, and we believe that subliminal laser might improve the outcome further. So what about another condition? So is there any other things that subliminal laser are able to use? Now for this, for today, I only go to choose one more condition. I think there's a few other things that subliminal can use. But certainly for CSR, it's really a very good option. As you can see here, there is a local leakage point, and you can just do the laser, and it's quite straightforward. And then you can actually see the result with the treatment very straightforward and very easy to do. And there's another case that this case of a much chronic edema, and actually that had got fibrillary noise material, and even those chronic cases that you can still have a very fast resolution of the fluid as well as the fibrillary noise and material. And then if you have another case that this is really close to fovea, a lot of people were concerned about that. And again, with ability for no scarring treatment, and you can able to do that and actually have a good success for that as well. This is a chronic cases with more than 2 years of history of chronic CSR, and actually previously had the photodynamic therapy already. And yet that, you can see that there is still diffuse leakage in the fluorescein, and then also that have a plaque in the ICG. And again, in those cases that treated with micropulse laser and covering the whole entire RPE leakage area, and then you can using a very similar protocol that we devised for the DME, and also show very good result. So in conclusion, that in diabetic macular edema as well as central serous retinopathy, laser is still very relevant in 2021. I would emphasizing that anti-VEGF is extremely useful in diabetic macular edema. And indeed, that sometimes I do use PDT for central serous retinopathy as well. However, that the hassle, the expense, and sometimes that you can't even get the drug anymore, and make you think that why don't that you use subliminal laser first? And if you turn out that to be not successful, then you can go for PDT. And indeed, I have patients that who have PDT elsewhere and refer to me, and then they will not respond to PDT and then work successfully in central serous. I think that is certainly a case that we don't know which one of those two are better, but I think in some circumstances that we can actually see the benefit of a micropulse laser and a subliminal laser. Thank you very much for your attention, and that will be the end of my talk